Good evening, everyone. My name is Louise Hager, and it's my great pleasure as Chairman of High Cancer Care to welcome you to the 2021 Natalie Shipman Memorial Lecture. This is the second time we have done this online. We didn't think last time that we were doing it, but here we are again. I'm also delighted to extend a very warm welcome to Professor Daniel Hochhauser, the Kathleen Ferrier Professor of Medical Oncology at UCL Cancer Institute, and to Dr. Adrian Tuchman, Chairman of HI's Medical Advisory Panel. A quick housekeeping note, if anybody would like a CPD certificate, please would you email Jamie Hertz after the lecture, and any other comments, we are always pleased to hear from you, and any requests and any comments. Thank you. COVID's been really impacted on all of us in many different ways. And as an organization, we had to very quickly pivot as soon as lockdown started almost 20 odd months ago. And to be able to continue to provide our expertise and care couldn't be face-to-face, so how are we going to do it? So whilst we physically had to close our doors, we opened thousands of virtual doors. In fact, since lockdown, we have provided 18,872 individual one-to-one counseling and children's services. That's a 31% increase. So we are needing to extend our team of specialized counselors and therapists. But being able to connect through mediums such as Zoom, Skype, and telephone, we have really extended our reach, not just nationally, but internationally. And I'm delighted to welcome so many people from across the UK and abroad. It's a challenge for us to be able to meet this surge. The whole medical profession has talked about a surge in people needing cancer support services and cancer treatments. And we are seeing this on a day-to-day basis. We are seeing this surge, witnessing it. How are we going to meet this challenge? Well, 2 years ago, we launched our Big C campaign, where we reclaimed the Big C, which was traditionally known or associated with cancer, and we reclaimed it for HI's Big C of care. Last year, because we didn't have any we couldn't have any events, any live events. We had a wonderful match fundraising campaign last November called the Big Campaign, where the community literally opened their hearts to us and really embraced us. And we felt it was one big communal hug. This year, we are still not able to have any events. And so on November the 28th and 29th, which coincides with the first and second day of Hanukkah, we will be having another match campaign. And this is called One Big Community for HI, still keeping the Big C for HI. And it will reflect, there will be events and all sorts of things happening up and down the country across the community. We need to raise £3.5 million this year to make sure that we can carry on providing the expertise and care that really makes such a tangible difference to people's lives. So if anybody is interested in helping us in any way with this campaign at the end of November, please do be in touch with Jamie, and we will be in touch with you, no fear of that. So thank you for your past supports, and please God, your future support. So tonight, of course, this evening is dedicated to Natalie, Zichron Livracha, a blessed memory. And I would like to wish Susan and all the family long life. Susan, the picture of Natalie really inspires us on a daily basis. It's hard to believe it is 31 years ago, and I can't believe this is the first time we've actually put a picture up of Natalie at the lecture, because however much I could try and describe her, it just couldn't do justice, and even a still picture's not getting that bubbly, beautiful, warm personality. But even though it is 31 years ago, Natalie is so fresh in our minds and will continue to be so. She drives us forward to make sure that we can continue to do what we do. And Susan, all your hard work and everything that you have done, are doing, and will continue to do is bearing fruit. And please God, all of us should share good news. There should be, as soon as possible, as many good reasons that people shouldn't need HI. But until that point, we are here to do whatever we can do in every which way we can support you. And now it gives me great pleasure to go to Dr. Adrian Tuchman, who is going to chair the medical part of this evening. Adrian.
Thank you. Thank you, Louise. And Thank you all for joining us, and I hope you can hear me nice and clearly. Let me briefly introduce Daniel. He's a long-standing colleague, long-standing friend of mine. He's been a member of the medical advisory panel for CHI for many years and offered CHI enormous support. So thank you for that, and thank you for delivering the Natalie Shipman memorial lecture tonight. Let me briefly just tell you a little bit about Daniel. First appointed as a consultant, senior lecturer at the Royal Free Hospital. That was in 1996. He then joined UCLH, University College, in 2002 as a reader and consultant in medical oncology. And he was appointed to the Kathleen Ferrier Chair, Professor Hochhauser in medical oncology in 2007. Active in clinical practice in the treatment of cancers of the gut, gastrointestinal cancers, and been involved in clinical trials. Research is very focused on the development of novel targeted therapies within a laboratory program at UCL Cancer Institute. So Daniel's is Director of the Cancer Theme UCLH, Clinical Director of Cancer Research UK at UCL, Head of the Research Department of Oncology at UCL Cancer Institute, Co-Director of UCL Cancer Domain, Medical Executive Board UCL Cancer Institute, Chair Medical Advisory Committee UCL, and the Sarah Cannon Research Unit in the United Kingdom. So we are very, very lucky to have such an authoritative voice speaking to us tonight. I'm going to add a little bit more, and then I'm going to let Daniel speak. He's got national leadership roles, Cancer Research UK Scientific Committee, MRC, Molecular and Cellular Medicine Board, and you can see that I'm sort of just reading these off his CV, which is extremely long, understandably. Member of the Technology Appraisal Committee. This is the NICE committee, NICE Clinical Excellence, National Cancer Research Institute Colorectal Clinical Studies Group, and his, as I've said right at the beginning, a member of our Medical Advisory Board. So we're very honoured to have you speak to us, Daniel. Thank you so much, and the room is open to you. And can I just ask the attendees, if you want to put any comments or you want to ask any questions, put them in the chat box, and we will do our best at the end of the talk to answer those for you. So, Daniel, over to you. Thank you.
Thank you very much indeed, for that incredibly generous introduction, Adrian, who's a great mentor and colleague, and more specifically, thank you to the wonderful organization CHI, which I've been involved with for many years, who do such incredible work, and for the opportunity to give this Shipman lecture, the title of which is Individualized Cancer Treatment, Hype or Reality? Introduce some terms which I think are going to recur during this talk. I'm going to interchangeably use some terms which are slightly different, but for convenience, we'll use them the same: personalized, precision, individualized, meaning, as I go on to say, that this is therapy designed for specific cancer, and specifically the therapy which is targets the specific genes and proteins of an individual cancer, and the rather ugly term pharmacogenomics, which is how an individual person processes the anti-cancer drugs which they are given. But cancer care is not just about drugs and surgery, although I am going to focus on drugs for the rest of the talk. It's a lot more than that in cancer care. And it's not just between the relationship between a physician and the patient, but there is a whole multitude and matrix of people and different influences that are very, very important for the care of anybody with cancer. And that is illustrated here. It's not just a doctor-patient issue. The patient has familial expectations, socioeconomic factors will play a major part. Community support is vital, and of course, as everybody here knows, how fortunate one is to have the support of CHI. Not every community is so privileged to have such support. Different religions and cultures and ethnicity have their own particular ways of approaching cancer, and that impacts on the patient and their expectation. And similarly, the doctor themselves, a very simple issue is whether the patient's NHS or private. To my mind, and I'm sure in the minds of everyone here, you should be entitled to the same equality and excellence of care, whether you are an NHS or private patient. And maybe that's something that can come up in the discussion. Resources are clearly there and available in this country to treat cancer well, but are also limited in certain aspects. And there are assumptions of the doctor, of the physician about the patient and what the aims of the treatment are. So it's not just a question of physician and patient. There are numerous other issues that will impact on that. Now, what is meant by personalized medicine? It's a medical model that means that patients are not just one undifferentiated group, but that medical decisions and practices and interventions, they're tailored to the individual patient, and it's based on how they will respond to treatment or how much risk they will have, rather than treating everybody as if they have the same condition. And in order to illustrate this, I will just briefly outline a patient, a 64-year-old man who's diagnosed with bowel cancer, colon cancer, undergoes surgery to remove that cancer, removal of the right side of the bowel, hemicolectomy, and the pathology of this illustrates that the patient has had the cancer completely removed. There is no sign of spread anywhere, which is called M0, and the cancer is localized and is staged as what's called T3N1, with 5 lymph nodes out of 26 involved. This is a stage 3 cancer. And the recommendation given to the patient is that their chances of cure are good, but they should have 3 months of combination chemotherapy with 2 drugs there to reduce the risk of recurrence. To just illustrate what this involves and what the decision making is involved at the moment, which is, in my view, an unsatisfactory state of affairs. If you take 100 patients who are in that group, which we see at least in UCLH, 100 patients with this every year, at least 100, of those, 50 of those were cured with the surgery alone. They did not require any additional chemotherapy. That was it. They only needed the operation. And a further 28 of those patients will unfortunately recur. They can still be treated successfully, but they will recur despite having had chemotherapy. So unfortunately, although they may partially benefit from chemotherapy, they do not absolutely benefit from it. But 22 of these patients out of the 100 will actually be cured as a result of getting chemotherapy. That is, they would have had cancer and they will not get it because of chemotherapy. So when you put all of that together, you have to treat 100 patients to benefit 22, and 78 patients do not benefit from the treatment that they are receiving. This is replicated in virtually every cancer that that we treat, whether it's bladder cancer or pancreas cancer. We have to treat a lot more patients than benefit because we do not have the tools. Breast cancer is actually an example where it's a lot more sophisticated, but in bowel cancer, we are heavily over-treating patients. And if you look at what's called stage 2 patients who are low risk, you have to treat 100 patients to benefit 4 patients, which means 96 patients will have chemotherapy for 6 months to benefit 4. Now, 4% is not nothing, and those 4 patients will not get cancer, and many patients will want to have that for a 4% chance. But it certainly is not a satisfactory state of affairs when you have to treat that many patients to benefit only 4 patients. And of course, I don't need to tell the audience here that chemotherapy, despite all of the great advances that are made in anti-nausea, vomiting, and other agents, is associated with a multitude of toxicity. So that is the background. But in order to understand what we mean by targeted therapy, we've got to go back a little bit to what is cancer therapy itself. And there isn't time in this lecture to go over the whole history of chemotherapy, but the era really started with in 1930s and 40s with the development of the nitrogen mustards, with the first curable cancers such as methotrexate and choriocarcinoma. And for the first time, one was able to cure cancers with chemotherapy using what were called the antimetabolites and then using what was called the National Cancer Institute screen. So that was the situation until the 1960s, really a resurgence, a surge of interest in chemotherapy that really made a substantial difference to outcome. And of course, there was great optimism at that time, as there is now. This is an example, a lecture in 1981 by Lawrence Einhorn, who is one of the pioneers in the treatment of testicular cancer. And here he has written that the diseases of small cell lung cancer and ovarian cancer are similar to testicular cancer. And when one gets the right combination treatment, we will make a similar quantum jump forward in curative therapy. But unfortunately, although there were advances, there was not a quantum jump forward. There was a small incremental jump forward. Now, throughout the 60s and 70s and 80s, the era of chemotherapy continued. But in the 1990s started a new era, which we can call the era of personalized therapy, the era where the cancer treatment was going to be tailored even more precisely than before. And it did occur before personalized therapy, but this really became the focus of research with what are called the tyrosine kinase inhibitors, and particularly with the drug there, imatinib, Gleevec, in 1996. And in recent years, an absolute revolution with the field of immunotherapy. And personalized cancer medicine, which developed really over the last 20 years, is a concept which has come from our studies of human genes and have helped researchers design more effective treatments by looking at the genetic information in individual cancers instead of treating everybody in the same way. And personalized cancer medicine can have fewer side effects than other types of treatment because it's more specific and it affects healthy cells less and cells involved in the cancer more, thus reducing the toxicity. And personalized cancer screening or the cancer treatment can allow you to work out what the chances are of developing cancer and therefore screening people with particular risks of cancer, matching the treatment to the genes in that cancer. And this will be, of course, more effective, and also looking at what's called the risk of recurrence. How likely is this cancer to come back? And in order to do this, we have what are called biomarkers. These are markers that are found in the blood. They can be found in the urine. They can be found in other tissues as well. And we use these now to, number one, predict outcome. So we can identify targets in individual cancers. And I'll come back to that in a moment. Importantly, in some situations, we can predict side effects, looking at individual patients, how their body breaks down the cancer drugs. And these are two tests here, which are actually routine. One is for the breakdown of antimetabolite fluorouracil, the other one in brain tumors, temozolomide. And importantly, how likely is the cancer to come back? And these are two revolutionary tests used in breast cancer, the Oncotype and the Predict. So personalized treatment at this level of sophistication is new, but the concept of personalized treatment isn't in itself so new. They've been looking for 30, 40 years. Huggins in the 1940s and 50s discovered the role of androgen receptor in prostate cancer and the role of antagonism of that. HER2, B2 status in breast cancer goes back to the 1990s. And of course, the important finding that breast cancer could be treated with tamoxifen and later on with the aromatase inhibitors. So in some senses, we have been personalizing the treatment over a period of 20 to 30 years, but really not more than rather broadly. Now, we now have a very sophisticated way that we can actually look at lots of cancers and look at particular genes and make decisions on particular drugs. But when I mention hype, one still has to look at a graph like this one and realize that in the year of 2020, there's still only about 13% of patients who were really eligible for any form of genomically targeted therapy. That doesn't mean that they benefited, they were eligible for it. So first point is some caution is needed. By no means are every patient eligible for personalized therapy. It is still restricted and the benefit is even less than for those 13%. What do we mean by personalized drug therapy? Well, the first revolution is this drug here. Well, it's not a drug, it's just showing you on the left the c-KIT receptor, which is the target for imatinib, Gleevec. This was a real revolution when it came through in the late 1990s. A tumor called GIST, gastrointestinal stromal tumor, which was completely refractory to chemotherapy, didn't respond at all to any treatment, could be treated with a very specific inhibitor of the molecule shown on the left, with really dramatic results. In this slide here, you see it's a CT scan. I don't know if you can see the pointer here. I'm putting this on the right-hand side. There is a mass, that is the tumor. And 6 months after starting Gleevec, one can see that the tumor has gone away. And these patients can be cured. Some develop resistance and can be treated with so-called second-generation inhibitors. So this is a real revolution, a drug that targets one specific pathway, one specific receptor, and can wipe out the cancer. This is not uncommon, but it is not the situation in the majority of cancers. This used to be called oncogene addiction, meaning the cancer is addicted to one pathway, and if you can break that addiction, the cancer will not survive. And at the time, this was met with absolutely huge excitement. These revolutionary new pills, is this the breakthrough we've been waiting for? And you can see at the top, this is 2001, and we're now 2021, and we still have multiple cancers that we do not have the breakthroughs. So was that hype? Well, the answer, I think, is no. This was a revolutionary treatment, not just in these GIST tumors, but also in chronic myeloid leukemia, which it's had the most dramatic effects. But it's proven much more difficult than was originally thought to make this into something that will eradicate cancer. Now, here's another drug that was developed nearly at the same time. This is in melanoma, in which there is a gene called BRAF. This BRAF is mutated. These black dots here are basically what's called FDG PET, fluorodeoxyglucose PET. The cancer takes up sugar, which is fluorodeoxyglucose. The brain uses a lot of glucose, so that's very black. The heart uses a lot of glucose. You can see that at the top half. But you can see on the leg here, on leg of this patient, that basically there are multiple tumors which after literally 2 weeks have melted away. And the same is true of the other patients as well. Now, actually, this treatment, which is used now and is more sophisticated, because unfortunately a lot of the patients develop resistance to this, and of course, melanoma itself is now treated with immunotherapy in large numbers of cases. This was another revolutionary way in which you could break down a personalized treatment for patients with BRAF in mutations. And this same approach is used also in bowel cancer, in colon cancer, in patients who have a BRAF mutation. The drug has to be used in combination, but is also very effective. So that's drug therapy. But personalized therapy is a lot more than just drugs. It also can be based on taking cells out and altering those cells so that they can specifically be personalized to the patient who's being treated. And one of these great therapies is called CAR T-cell therapy, which stands for chimeric antigen receptor T-cell therapy. And this is taking each individual patient's own immune system cells, reprogramming them outside the patient, and then using them to target the cancer. And that is illustrated here. The so-called T cells can recognize and kill the tumor. Blood sample can be taken. The T cells are extracted, and then they are then engineered and infused back into the patient to recognize the specific T cells of the tumor. This is a treatment that is not without substantial toxicity, but is another revolutionary targeted personalized therapy that is completely transformed leukemias and lymphomas and is moving into other areas. And you see here again, I showed you again a PET scan here in which a patient with lymphoma that was completely unresponsive has actually responded by day 30, their tumor has gone away. So this is personalized cell-based therapy, and I showed you before personalized drug-based therapy. So certainly, these are revolutionary treatments. They are not available for all cancers, but they're in specific indications clearly revolutionary. This is a patient from UCLH called Emily Whitehead, who was treated by my colleague Claire Roddy, who had incurable leukemia, got 1 dose of CAR T cells. She basically continued and is now 6 years cancer-free with completely incurable leukemia. This is unfortunately not always the case, but in a substantial number of patients, this is really the situation at the moment, and we're wanting to extend CAR T cells to other cancers as well. And this, of course, has resulted again, as you saw before with Gleevec, again, in a revolution and much publicity. And again, this is very, very important. This is not hype. This is the truth that in this girl, she basically was able to beat leukemia with the treatment of CAR T cells. So clearly some indications absolutely unique and path-breaking. So the advantages of this personalized therapy are, first of all, you can increase the effectiveness of the treatment. You can avoid the use of unnecessary therapy. In certain cases, you have reduced side effects. Certainly treating with Gleevec compared to the chemotherapies that were used is an incredible effect. Treating the non-small cell lung cancer with the inhibitors of EGFR and ALK are unique and completely avoid many of the toxicities we saw, and of course reduce cost because you don't have such toxicity and such complications from treatment. So it seems to be a slam dunk. There are clearly advantages. However, there are also some significant disadvantages of personalized therapy. Sometimes the benefits are modest and the drugs are overused. This is the case in the United States for sure, where a number of incredibly expensive treatments have been adopted into practice with minimal improvement in patient outcome. The second problem, which is the most important, is that resistance to treatment develops in a number of different cancers. These treatments are extremely expensive. And finally, cancer is not just one disease, even within one individual. It is what is called heterogeneous. It is a mixture of different types of disease and different types of cell. This is just a picture from my colleague, Charlie Swanton, who I think is probably one of the great world leaders in this field of cancer heterogeneity, which has incredible implications because you're not just looking at one cancer. In between cancers, they are genetically different, but even within the same cancer, you have the red, the blue, the green cells there. They are different. Some will respond to one treatment, others will not. They have a different pathway. So you can eradicate with chemotherapy or with a targeted therapy all the blues and the reds, but then the green one will grow back. And this is really very important. The cancer cells are uniquely adaptable and can actually keep switching on alternative pathways, and it's what's called the problem of heterogeneity. And this next slide is a little bit complex, but actually just summarizes it all, and I'll just briefly go through it. On the left side, you have a drug-sensitive cancer. You're using a drug to block what's called this RAS. This RAS is a pathway that's switching on a lot of genes, and on the far left is resulting in proliferation and cell survival. And using the drug, which is in red, you block this, and the patient is therefore, their cancer will shrink. But unfortunately, what happens in practice is when you look at B, which is the third from the left, you see that mutations develop in the cancer that block the drug from binding. And consequently, the pathway is switched on again, resulting in proliferation and the cancer growing. And the one next to that is that, yes, your drug works, but then another pathway is parallel and there's redundancy in it, and that can switch on the pathway as a parallel pathway. Or the cancer can just switch on downstream and completely ignore the drug and therefore switch on downstream. And finally, a completely different pathway can result and be switched on and lead to proliferation and cell survival. And of course, this is schematic, but it illustrates that targeted therapy doesn't always work because there are so many mechanisms by which a cancer can develop resistance. And I'm happy to talk afterwards to how one might deal with this problem. Here's another issue, the cost of the most expensive cancer drugs in the US market, the top one being actually a vaccine for prostate cancer, and I haven't put in all of the CAR T cell and all of the other therapies. These are expensive therapies, and it is not clear that even the United States healthcare system will be able to afford a huge increase in expenditure on cancer drugs. Average US monthly income pre-tax $3,600, and the prices of these, which are just colossal. This is the monthly cost of these drugs. The next important thing to know is that does one have to go to the top person, or as is often said in certain circles, the top man? Does one have to go there, or is uniformly good standard of care available? Now, actually, the way the system works at its best now in the NHS and privately is that cancer specialists work in multidisciplinary teams. They work, not just oncologists does not work by themselves, they work with physicians, they work with pathologists and radiologists and palliative care and symptom control specialists. There is no person who's working completely by themselves. There is no genius who's working away and knows things that other people don't know. The reasons for treatment are given on the basis of trials, on the basis of uniform standards of practice. And it is important to know that more treatment does not necessarily mean better treatment. So those are an example of some of the really very important personalized cancer therapies that are being used around the world and around in cancer treatments. So where do we go from here? Is it hype? Is it hope? Well, there are several very, very important areas where I think cancer treatment really must go in order to be successful in the future. The first is something called circulating DNA, which allows you to to precisely identify the type of cancer that might develop in the future. This is an incredible technology that truly is revolutionary. Now, I've mentioned here the company Grail, but there are other companies working on it. There's a big Israeli company works on this as well. And the idea is that cancers shed DNA, the genetic material. This is shed into the bloodstream, and using very, very precise selective ways of picking up this DNA, you can identify potentially in the blood cancer before it becomes apparent even on a scan. Now, whether that will result in improved outcome or not is not clear, but there is currently major study going on with circulating DNA in all sorts of indications. The next way is identification of patients at risk. And within the Jewish community, we know well that there are certain patients who are at risk for particular cancers, and those cancers will also respond to therapy very differently from other cancers. For example, BRCA mutation, which is common BRCA1 and 2, a causation of breast and ovarian, but also other cancers, commoner in the Ashkenazi Jewish community, picking up what's called germline, meaning that this is in the inherited DNA of the patient, allows one to identify patients at risk and focus screening and treatment on the patients who are at risk and not indiscriminately at people who may be at less risk. So what we call personalized cancer care is personalized looking at the cancer, but it is also personalized looking at our DNA, and that's called germline, the germline. Increased understanding of immune activation in cancer. I'm not today going to discuss immune therapies because that's another subject, but as you know, one of the great revolutions that's occurring at the moment is the fact that cancers are not immunologically the same as ordinary cells in the body. So when I was brought up and taught on cancer treatment, the idea was that immunotherapy was totally pointless because cancer cells are so similar to normal cells that basically they could not be recognized by the immune system. And this was really the dogma, that cancer cells were so much like ordinary cells that they could not be recognized. This turned out to be not true. And actually, it turns out that, of course, the cancer cells switch off the immune system. And if you can switch on the immune system, then you basically can achieve control or even cure of cancers. This is truly revolutionary in a number of cancers. There's those, for example, of melanoma, but also in lung cancer, and now moving to subtypes of breast, of colon and other cancers. So these are very important. One must also focus on quality of life. Quality of life, of course, is much improved if you're using a tablet as opposed to chemotherapy. And I think the toxicity profiles of most of the new treatments that are coming in essentially is resulting in a substantial improvement on quality of life as compared with what was there before. But importantly, we do have to consider, particularly in this country, where we do have restrictions on healthcare expenditure, and we do have other issues there, the cost implications. So this circulating DNA is illustrated schematically here. The cancer cells invade through into the blood vessel, and then often blood vessels grow to the cancer, a process called angiogenesis, and they shed the DNA into the circulation. And that DNA, which is the double helices that are shown there, can be picked up by screening and can therefore be used for diagnosis. I think this is really a very, very important part of personalized therapy, because it can be used not only to diagnose cancers early, but you can use it during the course of the patient's treatment to determine whether your therapy is working. This is called a liquid biopsy when it's done, so that instead of actually having to put a needle repeatedly into the patient's cancer, sequential blood tests can tell you, number one, if you are succeeding in treating the cancer successfully, and number two, if there is any resistance developing, what is the DNA profile of the resistance that there is. And importantly, this is a big trial that is now going ahead. It is organized by Grail, called the Galleri test, using a machine learning algorithm to examine circulating DNA. Interestingly, the person who is behind this trial is Peter Sassini, who works also closely and has written articles for Chai, and many of you may know him, an expert epidemiologist and statistician, and he is behind the design of this really vitally important trial, which is going to see, first of all, whether it can successfully be used to detect cancers before clinical signs or symptoms emerge, but also importantly, whether that affects survival. And that, I think, is very important because, for example, you might think it's self-evident that it's worth picking up a cancer early, but you don't really know sometimes whether the cancer is going to be one that may never do anything to the patient. It could just be there for a long period of time. And we know actually there are problems with screening of prostate cancer, for example, where you can pick up what are called indolent cancers that will never harm the patient. So this is really what we're looking to do in the future. This is a review article by James Allison and his wife, Padmini Sharma. James Allison won the Nobel Prize for his incredible discoveries in the field of immune activation 2 years ago. And essentially what this graph illustrates is how many people survive with prolonged period, and it's of course schematic. And until now, what we've been doing is shifting the curves. We've been improving the time that patients are alive. And we've had very, very good success doing that with chemotherapy. And we've had very, very good success doing that with genomic therapy. But now what we're doing is using immune checkpoint therapy, which is in green. We're finding that there are patients in some cancers, as I say, some bowel cancers, and certainly melanomas and others, who are surviving really for such a long period of time, one could consider them to be cured. And we're now finding that if you combine the targeted therapy, the genomically targeted therapy, and the immune checkpoint therapy, you can substantially and significantly improve the percentage of patients who basically are living for a prolonged period of time. So how does that leave the 64-year-old we mentioned in the beginning? What will happen to that patient? We, for 20 years, has had no improvement whatsoever in deciding who to treat with stage 3 colon cancer. But we're entering already a revolutionary stage. This is a slightly complex graph, but the concept is actually quite straightforward. At the top of the graph is somebody who's circulating DNA negative. That patient has a very good chance of cure. And basically, it's not clear whether you should be giving those patients chemotherapy or how effective it is. So you would de-escalate, and a certain percentage of them will be 100% cured by the operation itself. So we would test this patient for circulating DNA. If their circulating DNA is positive, then they will need chemotherapy or even escalation of standard treatment. And when they complete their chemotherapy, they will again have their circulating DNA measured so that we can identify the risk of the cancer coming back. And this is being done now extensively. It's still trialed. It's still not accepted therapy to do standard testing of circulating DNA on patients because there are not really accepted standards at the moment, but they are moving rapidly in that direction. And I would guess probably the first rollouts will occur next year when we will, instead of just saying to somebody, you need to get chemotherapy for 3 months, 6 months, we will be able to tell that patient what their risk is and whether they're going to benefit from the use of chemotherapy or other therapies. So, summing it all up, personalized cancer medicine, what will we do in the future? At the moment, we've just been having a patient, we get a biopsy and it confirms whether they have cancer, and then we've given all of the patients exactly the same treatment. And this has been very effective, obviously, in many cases, but it's resulted in side effects, it's resulted in overtreatment. What we now want to do is genotyping, look at the specific DNA, and importantly at the bottom there, look at the pathways that are switched on. More than the genes, we need to know the pathways. This is in its infancy, but I think this will be the true revolution when we discover what the pathways are in cancer. And then treatment selection occurs in a variety of ways. Basically, you match the cancer to the drug and you use screens to match the tumor to the drug. And this is considerably more specific and sensitive. Rather than doing repeat biopsies, we can do repeat scanning. We can look at the bottom there actually at tumor cells that are circulating. But importantly, as I've just mentioned, we look at circulating DNA. So, individualized cancer treatment, is it hype or reality? Well, it's reality. every cancer really has some personalized treatment that can be given, some less, some more. So it is reality. However, one must still have a certain dose of skepticism about the hype that is going on, because there certainly is an overstatement of the benefits in certain cancers. And unfortunately, in cancers which I'm involved with, there still are challenges in pancreas cancer, in bile duct cancer, and in colon cancer in terms of how much benefit these personalized therapies will give. But nonetheless, one can say we've moved a long way forward, and one's always looking and saying there's a revolution and a breakthrough and magic bullets. But I would say, yes, this is a real revolution, but still a certain degree of awareness of the potential overstatement of benefits is still very important. And unfortunately, as of now, there are still many patients who will not benefit. Thank you very much.
And thank you very much, Daniel. That was absolutely fascinating. Can I just first of all say to the audience, if you've got any questions, could you email? The email is on screen. Jamie Hertz at High Cancer Care, who'll hopefully ping the email question to Daniel and myself. So please email any questions. Number one. Number two, a couple of things you brought up, Daniel, and I think I'll start the conversation. Is cancer being transformed into a chronic illness? Is it sort of, is that the change that we're seeing? Because it certainly feels like that from a clinician like myself who's looking at these things from, you know, from the periphery.
Yes, I think that's very true. I think talk of cure is, there are some cancers that are being cured, but many of them is exactly what you say. It's a chronic illness, and there are cancers that are continuing for people are living with certain cancers which have spread for really very prolonged periods of time now, which was not happening before. And that leads to its own other issues and its other challenges, which is actually in the field, in your field, in terms of not only in symptom control management, and this is where Chai comes in, but tremendous psychological and emotional issues that involve with prolonged use of cancer when it becomes a chronic disease. Hopefully, in the end, a chronic disease like others.
Daniel, you've gone blank there.
Have I? Can you hear me? Hello? Lisa says we can hear. So it's only, I think, Adrian who cannot be heard. So I'll continue with that. Chronic, it is a chronic process. And certainly it will be increasingly so with the new treatments that are through. So the simple answer is yes, it will become a chronic condition. So Laura has asked a question, are outcomes different depending on where in the UK you live? And I think that's a really important issue, because it's really important that basically people do not lose out because they live in certain specific areas in the country. But there is actually, unfortunately, there are parts of the country in which in which you can see actually. There's a study this morning actually that was published in the newspapers this morning about the major health inequalities and what that has resulted to in cancer outcomes. Now, I think that's more often than not is a problem of late detection of cancer, and that has become a problem during COVID, where the bottleneck has not necessarily always been the treatment of cancer, that has been there, but actually with the diagnosis of cancer, such that endoscopies have taken longer to organize, colonoscopies have taken longer to organize, and cancers that should have been detected at an early stage are being detected at a late stage. And that is not uniform in the country. In central London, around UCLH and Imperial and so forth, I think there's still, even there are problems. But essentially, I think that the issues of late diagnosis are really the worst ones. Treatment, yes, there is still some heterogeneity. There's still some difference in treatment. And I think access to trials is very important. So I think that any patient who goes anywhere in the country should have access to trials. And there are a number of very good places to go to for trials, provincial academic centres, and within London, many centres as well. So yes, there is unfairness, and that's the job of what's called these multidisciplinary teams and to address, to make sure that there's a uniformly good standard of treatment in the country. So someone has asked, what is the latest on treating pancreas cancer? That's quite a big subject. The latest on treating pancreas cancer is, I don't know what I mean, well, so pancreas cancer is a very challenging cancer to treat. When it can be operated on, clearly that's the only possibility of cure. Subsequent to that, it's clear that chemotherapy has a massive impact on the outcome after operation, what's called adjuvant chemotherapy. But in advanced pancreas cancer, there are some improvements in the combination chemotherapy, but unfortunately, what we call the targeted therapies have as yet only been applicable to a minority of patients with pancreas cancer. So the revolution I mentioned is there, but is really not actually covering pancreas cancer. Judy has asked, what do we feel about patients going abroad for treatment when there's little chance of survival here in the UK? And that's a very important question. And it's addressed very often. The idea is that, perhaps somewhere else is better treatment. The treatment in the United States is better. The treatment often in Germany is better. I think that it's very rare that you need to go abroad for treatment, actually. I have never seen a patient go abroad who ended up getting better treatment for going abroad. I mean, I think people should do what they want to. It's their lives and it's their choice. But I must say, I completely think that anybody should be entitled to a second opinion in this country. But the idea that you do better because you go abroad, I don't think is true. We all go to the same meetings. We all go to the same conferences. Yes, there are certain drugs that are not funded on the NHS here. That is true. I think that's because they don't pass the NICE criteria for cost effectiveness. But essentially, I think that it's very rare that going abroad really makes a difference. Now, the cancer survivals are not good here in the UK compared to other countries, although I not always believe some of these studies that suggest that you're better off in Poland, which in fact is published there, because I just think the statistics in this country are much more carefully kept than they are in other countries. But where I think is the problem in this country is the screening for certain cancers is not very good. So recognition of early breast cancers, recognition of bowel cancer, and recognition of how important it is to get certain symptoms looked at, that to me is the biggest bottleneck that there is. Someone has asked, how you mentioned the cost of more targeted treatments. How will we address this, and how likely is that these new treatments will be funded if the evidence is there? If the evidence is there and there are certain criteria, and I won't want to go into the exact costs that are required by NICE. NICE has an instrument called QALY, which is Quality Adjusted Life Years, and how much a drug has to be in order to meet that criteria. Actually, NICE has approved the immunotherapies in many of the indications. It's approved in lung cancer. They've just approved it in gastric and esophageal cancer. So these are the immune therapies, pembrolizumab, nivolumab, which are extremely expensive. So I think these treatments are being funded by the NHS. However, I think that clearly there are certain drugs that we use, for example, in bowel cancer that are not funded, such as Avastin, bevacizumab, and other drugs. How likely is it? Well, I think that the cost issue is one that I think is crucial. But at the end of the day, a decision is made in this country as to how much money to spend in the NHS. And certainly there should be equity. And it's a problem that patients who are going privately do get different drugs in certain cases than those who are on the NHS. That, I think, is a problem we could discuss the ethics of, but that's the system that we live in. And I think probably in the future, as some of the drugs come off patent and become generic, those costs should fall. So at the moment, yes, it's a problem. I don't think there are really any dramatic, I mean, I think there are often, if something is dramatically effective, it generally will be passed by NICE. But, understandably, patients want everything possible. And sometimes the NHS does not pay for it. And then you have an issue. Do you mortgage your house to pay for immune therapies? And that's where it's the role of a doctor to say how much benefit you get from that. I don't have any other questions that have actually come through particularly. I don't know if anybody has any treatment. And I think that really, as I say, one of the issues that I think is important is that not everybody gets their cancer genomically analyzed at the moment, but there is a limited form of genomic analysis of almost every patient. So for example, the patient with colon cancer, you don't on the health service get full genomic analysis, but you do get, for example, an analysis of what's called the RAS mutational status, the BRAF mutational status, and what's called mismatch repair deficiency. And that accounts for about 90% of targeted therapies, if not 95%. So I don't think at the moment, my understanding really would be that NHS patients, first of all, should have access to clinical trials, and secondly, they should have access to genomic therapies as well at the moment. But clearly, it is restricted in this country. So I think that essentially, we've lost Adrian. He has sadly ablated from here, but we have instead Louise has come back. So Louise, in a staggering display of ineptitude by Adrian, he managed to cut himself off. He's still a wonderful, warm human being.
This is being recorded. This is being recorded. He will hear that. He will hear that. So, I mean, you are incredible, Daniel. Thank you so much for a very informative, comprehensive, but I think most of all, honest appraisal of what the situation is now. I think that's very much your hallmark, to say it as it is, but with compassion and with humor, which we all need. But really, thank you so much. We've all learned a lot here. And if anybody would like a recording of this, please be in touch with Jamie, because there was a lot to take in. And we are extremely grateful for your time. We know this doesn't happen out of the air. And thank you for all your time and effort in such a wonderful presentation. And on behalf of all of us, go and have a nice whiskey now. I think you
Can I just make one point about Adrian?
Yes.
Because his ineptitude. He's actually a wonderful person. Adrian, for those who don't know, is actually the chair of the High Medical Advisory, and Adrian has tirelessly actually improved the quality of medical input into High over a number of years, and his contribution is really fantastic. And I really have a great respect for Adrian, who is not only in his own field of symptomatic care, and you of course have introduced clinics into High, clinics with the Royal Free, with Rachel Craig, that are actually looking after patients' symptoms, quite apart from your other issues that you do. But I think that we have to be very, very grateful to Adrian for the work that he's done, really over a prolonged period of time, really to, he's back.
He's back.
So Adrian, we're just saying what a wonderful job that you have done, and how grateful we all are. And it's a very important balancing task between the medical management, the symptom control management, and all of the supportive services that High give. And so thank you very much for that, Adrian.
No, as you know, my pleasure. Apologies for going dead then. Daniel, that was a brilliant talk. So thank you. It really was. As I said, we're all very lucky to work with each other. We really are.
Thank you very much.
On that note, good night, everyone. Thank you for joining us. Thank you so much. Take care. Bye.